Happy evening, viewers, and a very warm welcome to yet another episode of GarbhaSandesha, episode number 44. And this episode, we will be talking about male infertility. And to talk on this subject, we have Dr. Anitha Manoj, who is the fertility specialist at our Hanmantnagar branch. Dr. Anitha has over a decade of experience as a gynecologist. She specializes in infertility and holds a fellowship reproductive medicine degree from fellowship from RGUHS. Dr. Anitha's prime motto is to ensure safe medical care for patients. She is one of the best fertility experts in Bangalore. She is a member of FOXY. Next, we have Dr. Deepthi Venkatesh, who is a distinguished fertility specialist with over 7 years of experience in the field of obstetrics and gynecology. She has done her MS OBG from prestigious BMCRI and fellowship in reproductive medicine from RGHS. A very warm welcome to you, both of you doctors.
Thank you, sir.
I would like an opening remark from both of you on the topic of today's, that is male infertility. Dr. Anitha Manoj, you can take the lead, please.
Yes, sir. Thank you. So today, the topic is male infertility. We all know, infertility means not able to conceive. Within 1 year of marriage, if they are having unprotected sexual life and still they are not able to conceive, that is called as infertility. And why we are giving so much of importance to male infertility? What are the causes for infertility? It can be from a man, can be a man, like male reasons. It can be female, or it can be combined also. Sometimes everything will be normal. It can be unexplained also. That is, around 30% will be female causes, 30% will be male causes, and 30% will be combined causes. And in 10% of the cases, all the investigations, that is basic investigations, will be normal. Still, we won't be able to find out where the cause is. That is called unexplained infertility. So the male infertility, in previous generations, when the couple will get married and they are not able to conceive within 1 year, the commonest blame is towards always the female. That means they're not able to conceive. So the problem is with the female. So either they will take the female only to the hospital for evaluation, or make the men get married, remarry again some other female for children. So now the concept has changed. The understanding of the infertility has changed because of the education. So now the male factors are also is on the rise because of maybe the food habits, exposure to the pollution, or our lifestyle also. So the 30% causes, it's because of the men. And what are the different causes for this? How to evaluate, how to treat, all these things, what are the different options available to treat the male infertility? We will look into in depth today in this short discussion about the male infertility. Thank you.
Thank you, madam. Dr. Deepthi, your take on today's topic?
So this is a very relevant topic. Like madam said, usually we see, even today with so much education and awareness, we see sometimes only the female partner coming in, getting evaluated, saying the male is not ready to come, just tell us when to have intercourse and we'll do that. And we do that. And we, that takes away some of our time. Finally, when nothing is working and the male comes in and gets an analysis, which is a very basic test to diagnose male fertility or male infertility, we see that the problem lies there. So my advice would be for couples to come together, get evaluated together, so that the time to conception or the time taken to achieve pregnancy, which is your end goal, and a live birth will become shorter. So this is what we'll discuss today. What is male fertility, what can be done to diagnose, and what are the treatment options available to tackle the same.
Thank you, madam. Dr. Anitha, the first question comes to you. What is male infertility?
So as I already discussed, male infertility is nothing but infertility means pathology with the reproductive system. The pathology lies in the reproductive system. So male infertility means the pathology lies in the male reproductive system. So how they can present means it can be physical. That means they might have erectile dysfunction. They might have like premature ejaculation. They're not able to retain the erection, or premature ejaculation, that is physically, or they can have systemic diseases also, something they're suffering from long chronic diseases like liver, kidney, all these things, and they're taking multiple drugs for all these things. And it can be problem with the main problem lies in the semen analysis also. That is either problem with the production of the sperms, that is they're not able to produce adequate number of sperms, or problem with the expression or reaching out of the sperms, problem with the secretion of the sperm, that is sperms are not able to meet the egg because there is lack in the ejaculation, or that is obstruction. It can be problem with the production, that is it can be non-obstructive, problem with the expression, that is obstructive azoospermia. So these things mainly cause the male infertility. We have to evaluate, basically we have to do a simple semen analysis to see what is the volume, number of the sperms, and mainly motility also. So number, motility, and normal forms, like even like how we have head, neck, hands, and legs, like that sperms also will have. We have to see how normal are these sperms. So we will evaluate this and find out. So any problem with all these things, the causes can be multiple factors leading to finally this only. That is either production, lack of production, or lack of expression of the sperms. So we have to find out what is the problem and what is the cause, root cause for this problem, and treat accordingly.
Thank you, madam. And Dr. Deepthi, next question is coming to you. Can genetics play a role in male infertility?
Definitely, sir, it can. So genetics alone, genetic causes alone contribute to about 15 to 30% of the male infertility. When I say genetics, it doesn't mean just passing from father to son. No, even those are seen. But in male infertile population, when we do genetic testing, that is the karyotyping or the Y chromosomal microdeletion, which is the normal test that we do, we see that the incidence of chromosomal abnormalities is much more than in the general population. When I say chromosomal abnormalities, it can be with the number. All of us have a fixed number of chromosomes, so the number might vary, or it might be a structural abnormality. So what is the implication? These people with structural and numerical abnormalities might have deficiency in sperm production, or even if there is sperm production, the sperm function might be deficient, or they might not be producing sperms at all. So once we get all these tests done, we will be in a better position to advise them regarding the further steps and how to go about to achieve a pregnancy, whether it is possible with their own sperms, and what are the options available. Also, there are some disorders like say cystic fibrosis, which can go from generation to generation. And we see this. So it is genetic testing becomes extremely important in such cases. So yeah, genetics does play a huge role in male infertility.
Thank you, madam. Anitha, madam, what are different types of ART used for male infertility?
Yes. So this is the commonest question. Like like we do a semen analysis, and we'll find out that there is pathology in the semen analysis. It can be very less number. Normal number should be more than 15 millions. So it can be less number, or it can be nil sperms also sometimes. As Dr. Deepthi said, so genetic causes also play a role in this. So if the sperm production is less, the number is less, that is less than 15 millions. If the count is between 10 to 15 million, they can go for intrauterine insemination. This is one method where they can go, but provided the motility should be good, at least 30% motility, that is the moving sperms has to be good, then only the sperm can meet the egg. And the normal forms has to be adequate. And we are concentrating only on the male here. There should be a female partner also, that is ovulation should happen, the tubal patency should be normal, the uterus should be normal. So provided the female partner is normal, concentrating only on the men. So if the count is between 10 to 15 millions, we can go for intrauterine insemination. If the count is much lesser, so we have to evaluate the men. So go for in vitro fertilization, either IVF or ICSI methods. If the count is nil, that is called azoospermia, we have to definitely rule out the genetic causes routinely, because there can be associated genetic factors where even if we go for surgical methods of aspiration, we might get sperms, but we may not be able to use these sperms because we might transfer the same to the kids, or it can go for implantation failure or pregnancy failures, or if the female conceives also, if the male partner is having some genetic issues, they might go for recurrent abortions also. So IVF or ICSI. So either if the count is less, intrauterine insemination. If the count is too less, go for IVF after proper evaluation. If the count is nil, azoospermia, still we have option for their own pregnancy with their own gametes. Don't get panic thinking like I'm azoospermic, I don't have my own sperms, so I won't get a baby of my own. Definitely don't think. There are advanced techniques like PESA, TESA, testicular biopsy, and many other methods where we can retrieve your own sperms, culture them, do ICSI, make embryos, and they can conceive also. So recently, I'll give you an example. Recently means last year, one couple came, he is azoospermic, outside being treated with multiple cycles of donor insemination. IUI with the donor sperms failed, and they have done IVF with the donor sperms also, that also failed. They walked into our GarbhaGudi OPD. We evaluated, our andrologist evaluated the person. We went for PESA, we retrieved the sperms. His genetic components were normal, only karyotyping everything. And with the first, they got only like maybe few embryos only. With the first attempt itself, they conceived. Now the baby is 3 months old. It's very much healthy. So like this, there are multiple examples also. So even if anything, any problem with the men, don't get depressed. We have all the solutions. Just walk in, get evaluated, and get treated.
Thank you, madam. Dr. Deepthi, there is a question from a viewer. Can we improve sperm count by naturally by food habits and lifestyle?
Definitely. So lifestyle and our diet plays a very huge role in fertility, whether it's male fertility or female fertility. First of all, they have to make sure that they're within the ideal BMI. That is, there should not be obesity or being overweight itself hampers the sperm production and also the sperm count and motility. So first, maintain an ideal BMI. Make sure you include a lot of fresh fruits and vegetables, which are a very good source of antioxidants in your diet. A diet rich in vitamin C, which is found in oranges, or vitamin C supplements, chewable tablets, and zinc. Non-vegetarians, of course, get a good source of zinc, but vegetarians may have to take supplements for the same. And avoid things like smoking, drinking, which have a long-term effect on your semen volume, semen count, and your motility. And also, coming to lifestyle, make sure you're active. At least 30 minutes of exercise daily, and do not go overboard with exercise because extreme exercise amounts to physical stress, and that also may hamper with your sperm production and motility. So these are some ways to increase your sperm production with the modifications in your diet and lifestyle.
Thank you, madam. Next question comes to you only, Dr. Deepthi,
yeah.
Which part of it has been answered already by Anitha madam. But still, we would like a specific answer on this. What is azoospermia and how does it affect male fertility?
Okay, so azoospermia itself means absence of sperms in the ejaculate. So whatever they give for testing, when we see it under the microscope, we see absolutely no sperms, zero sperms. Okay, so just concluding it as azoospermia with one sample that they've given is not right. We usually tell them to give another sample at least 4 to 6 weeks apart. And then when we confirm that it is azoospermia, we further classify it so that we can give them adequate treatment. Azoospermia can be obstructive or non-obstructive. So then we have to do some tests to evaluate and make out which kind of azoospermia it is, because the treatment depends on the diagnosis. So we do reproductive hormone testing like FSH, follicular stimulating hormone, and testosterone, see the values and correlate to make out the diagnosis. If it is obstructive azoospermia, what does it mean? That the sperms are being produced in the testis, but there's a deficiency in the passage. Either there's an obstruction or some sort of deficiency in the passage so that the sperms are not getting expressed. So in this case, the sperms are present, but we have to take them out. So this can be done by directly extracting the sperms from the testis, which is called testicular sperm aspiration, or from the epididymis, which is a gland above the testis. This is known as percutaneous epididymal sperm aspiration. Both are surgical techniques, not very invasive. They give very good retrieval rates. Sperm retrieval rates range anywhere between 60 to 90%. And these sperms which are obtained can then be used for ICSI. We cannot use these sperms for intrauterine insemination because they are not motile, but we can use them for ICSI and give very good pregnancy rates. Coming to non-obstructive azoospermia, this means the sperm production might not be happening. So when we test the hormones and see that both testosterone and the FSH and LH are low, then we give them injections, hormonal injections. We give them initially for 6 weeks, weekly twice, and then we repeat a semen analysis and see if there's any sperm production. If the results are favorable, we continue the injections over a period of time, probably 9 months, and then we see retrieve the sperms by repeating the semen analysis, and then they can go for any of the assisted reproductive technologies, which Madam has already explained. So also while evaluating azoospermia, we have to make sure that they do not have any gonadotrophin exposure, gonadotoxin exposure, like maybe chemotherapeutic drugs or anything like this. Rule out any acute infections, acute stress, which may sometimes cause this kind of result.
Thank you, Madam. Thank you for that comprehensive answer. Dr. Anitha, there's a question from one Mr. Ramesh Hiramat. He is asking how to increase sperm motility and number of sperm.
So, Mr. Hiramat, already Dr. Deepthi has answered this question, like how to increase number, and someone has asked. So, to increase the motility as well as the normal forms, like we have to rule out any other, like first go for evaluation, rule out the cause, mainly where the cause lies, that we have to rule out. And basically concentrate on your weight. If you are too obese, you have to reduce the weight. If you are having your health, like lifestyle changes, like if you are too alcoholic, consuming lots of alcohol, or too much of smoking, too much of Wi-Fi exposure, or your occupational also, that is, you are exposed to too much of heat, like you are working in too much of heating environment, like how they do in mechanical things, or in the production side, you are working where you are exposed to too much of heat, always wearing like all tight clothes, traveling too much. So all these things you concentrate and decrease your weight, and with your food habits also, like increasing the healthy food habits, like more of greens, more of fresh fruits and vegetables. And if you come across, like our andrologist will evaluate you completely where the problem lies. There should not be any organic pathology or structural pathology associated. So in that case, like we can go for like medical supplements also, like antioxidants, all these things. They can improve the normal forms as well as motility to some extent only. There won't be any drastic change in the number or motility or in the normal forms. It can only a marginal change can be noticed over a period of like that. You have to take at least 3 months the medications. If you repeat after 3 months, then there will be a marginal difference, provided you should also, there should be contribution from your side also in lifestyle as well as other changes also.
Thank you, Madam. We have spoken about sperm morphology and number of sperm, but could we explain more on what is sperm motility and how does it affect male infertility?
Yes, see, we are speaking about number. The previous question only I told, it should be between around 15 to 16 million. See, for a female, there is only one egg which is getting secreted every month, getting released. And for that one egg, there are so many millions of sperms. You can question me, like there are so many millions of sperms, why this infertility? In this so many millions of sperms, it will get ejaculated in the outside reproductive system. These sperms has to travel through the uterus tubes and meet and fertilize the embryo or the oocyte, which is situated in the fallopian tube itself. So for this track to achieve, the sperms has to swim a lot. So there should be, the motility should be good. So the fast moving sperms should be at least 30 to 35%, and slow moving sperms in addition. So totally the moving sperm should be around 40%. If this motility decreases, So the number of sperms reaching the target, that is the oocyte, decreases when this itself, because on the way itself, these sperms will get tired and get damaged and destroyed or die also in the track. That is why we want that fast moving sperms. And the normal forms means, I already told you, the sperm has a head, neck, body, and tail. All these parts should be perfectly located. That is abnormal heads, abnormal neck piece, or abnormal mid piece. That is body. These forms also, they can get damaged. They won't reach the oocyte. So at least minimum of 4% normal forms is more than sufficient for them to achieve the pregnancy. If there is less number, then we have to go for other methods of fertilization. That it doesn't mean that you are having less number of motility, you're having less abnormal, more abnormal sperms and less normal forms, you cannot achieve pregnancy. So the natural conception will become difficult for them, but they can go for assisted reproductive techniques, which will definitely help them in achieving the pregnancy.
Thank you, madam. Dr. Deepthi, what is the success rate of male infertility surgery?
Okay, so there are various surgical options available. Like I already said, if there is some options which I already spoke about are PISA, which is percutaneous epididymal sperm aspiration, TISA, which is testicular sperm aspiration, wherein we take out the sperms by using an injection, aspirate it and give it. And the other options are testicular sperm extraction, wherein we take out a piece of the testicular tissue as well. So these are all the testicular surgeries that are available. The success rates of these are anywhere between 60 to 95%. And I'm very happy to say that our center has a very, very good success rate in terms of sperm retrieval. We get enough sperms to use for the present cycle and also for cryopreservation, which is freezing as a backup. The success rate of using these sperms for ICSI also is quite high, around 40% success rate of achieving a live birth. Another surgery that is commonly done for male infertility is varicocelectomy. What is a varicocele? It is the presence of dilated veins around the testis. This increases the temperature and then around the testis and decreases or hampers with the sperm production. So all patients who present with varicocele or are diagnosed with varicocele will not need a surgery. This will be decided by our andrologist. In case they're undergoing a surgery, then the success rate of such surgeries in centers will be around 70 to 80%, and the sperm improval rates is around 60 to 80% post-surgery. However, as a precaution, we would advise freezing one sample before undergoing the surgery. So I would like to add something to this. Any testicular surgery, the goals of these surgeries will be to achieve, get a good number of motile sperms and also adequate sperms to use for the current treatment and also as a backup, while also inflicting minimal damage to the surrounding tissue so that we don't, damage whatever tissues around the surgical site.
Thank you, madam. And Dr. Anitha, what are the symptoms of male infertility, if there are any?
Yes, so when the discussion started only, we are telling, it can be like, one is mainly not able to make the wife pregnant, that is not able to conceive. Even after marriage, after 1 year, provided when they go for evaluation, the female partner is normal and coming to the, male partner has some pathology, that is one thing. And physical changes also, like erectile dysfunction or the premature ejaculation. So these two things, the person itself can make out. So other things, and when ejaculation finding, the quantity is very less. So these things, and prior history also, the person might know he any mumps, like he had suffered during the childhood or anything, severe viral infections, high grade viral fever, prolonged viral fever, mumps, or any other infections or inflammations, or he's having some chronic systemic diseases related to liver or kidney, on multiple drugs, or he is habitually taking many drugs also, like even for a simple acid peptic disease, like thinking as gastritis, and he is taking the antacids frequently. So all these things, and any psychiatry, he's on he has any psychiatric illness on antipsychotics, or drugs he's using like narcotics, and then severe alcoholic, so smoking, like a chain smoker, regularly smokes. So all these factors, and family history also, like in the family, if like his siblings, maybe brothers or cousins, cousins having similar infertility history, not able to conceive even after years of marriage. So all these things they have to keep in mind so they can present. So in a female, it can be mainly reflect in terms of menstrual disturbances. But in men, if we ask for symptoms, it is difficult other than the erectile dysfunction and premature ejaculation. We have to assess by history-wise, we have to assess and go for the clinical examination and evaluation. And one simple test, that is semen analysis, which can diagnose so many things.
Thank you, madam. Dr. Deepthi, can certain medical conditions such as diabetes or hypertension affect male infertility?
Yes, sir. So medical comorbidities like diabetes and hypertension can definitely affect male infertility. In diabetes, we see that especially uncontrolled or untreated diabetes, we see that impotence is very common, almost up to 50%. So diabetes interferes with the normal sexual function by both neurological and vascular factors. And hypertension, the drugs that we use for hypertension itself can interfere with the sexual function and also with the semen parameters like alpha blockers, beta blockers, whatever we use. So usually when they come and they're on treatment for diabetes and hypertension, it is better to go get a physician opinion and see whether the medications can be changed. Especially when they come to us for evaluation, we do test their sugars and see if everything is in order, because these are some simple things that we might miss and keep on jumping to the next step, while the cause would have been sorted out with a simple sugar test.
Thank you, madam.
I would like to stress that please keep your sugars and hypertension or BP under control before going for any kind of ART or assisted reproductive technology.
Thank you. Dr. Anitha, what role does age play in male infertility?
Yes, sir. See, this is one commonest thing, because nowadays the couple are undergoing late marriages. They're going, even if they get married, also they're planning the pregnancy late. Let it be a female or a male. So females undergoing, like going for marriage after 30, men going for marriage after 35. The age plays a very important role in both the cases, let it be female or male. See, if the female, in case of female, if the egg reserve, that is the oocyte quality or egg reserve, starts declining after 30 years of age, means in men it can start after 37, 38, or even after 40 years. There will be, the sperm production might get slower, the number will come down, and there will be motility, and the normal forms also will come down. So not only this, the quality of the sperms, that is with respect to the DNA, that is DNA fragmentation index, DF5. There is one parameter which we assess to assess the quality of the sperms. So this DF5 will increase as the age increases. That is, it should be it should be less than 15% when it has to be normal. If it is 15 to 25%, we'll take it, we'll consider it as satisfactory if the couple is undergoing for IVF. But for natural conception, it has to be less than 15. So when the age advances, or when they're when they're getting exposed to all these high risk factors, which we have already mentioned so many times, then this DNA damage will increase and it can become more than 25%. If the age goes beyond 40, it can become 40, 45%, 50% in such cases. So most of the sperms, the quality will decrease, and these sperms won't be able to penetrate the oocyte and cause fertilization. Even if it does so also, the embryo quality will be very poor. And even if the implantation occurs, pregnancy happens also, these pregnancies may not last for longer. That means they can go for either anembryonic gestation, where there will be, there won't be any fetus inside, they'll go for abortions, or they can go for missed abortions, or even the late abortions also, late first trimester abortions also, because of the chromosomal abnormalities or the pathology in the sperms itself. That is why age plays a very important role. So age, mainly, it can affect the number, motility, sperms, as well as the DFL.
Thank you, madam. I would like to remind our viewers, and we are happy to announce that we have come up with a new center, that is our sixth center at Nubial Road, right opposite to Ramaya last week. So because of this, we are offering free consultation and free registration at our 6th New BL Road Center. I request our viewers, whoever qualifies to utilize this particular service, to avail of this offer. And then my last question, as we are running out of time, Dr. Deepthi, how common is male infertility?
So male infertility, as madam has already said, purely male infertility in our infertile population, we see about 20% being directly related to male cause itself, where the female is absolutely normal after evaluation. Another 30 to 40%, there is a contribution from both the male and the female. So it would be safe to say that whatever cases we see or whatever clients we come across, about 50% of them, or some, now the incidence is actually increasing because of our lifestyle and all, but even otherwise, at least 50% of them will have some male component, and most of the times these can be easily remedied. So it depends on the infertility duration, what is the cause, and what is the partner's age, that is the female's age and fertility status. And based on all this, we can take a call and take it ahead. But please do not neglect it, because the incidence is definitely increasing.
Thank you, madam. Thank you, both doctors. That's all we have time for now. Thank you. And then our viewers, let me remind the viewers that in case you have specific topic for our doctors to discuss on it, please do mention it in our comment box. Next episode will run on it. Thank you, viewers. Thank you, doctors.